on board. This is the session about learning from successes and mistakes and risk communication community engagement. And to give you a quick overview of the session, we will start with my colleague Arianna S, who is an SBC or an advisor for behavior change and community health at Save the Children US. And she will talk more about experiences with risk communication and community engagement approaches from her vast experience, not only with COVID-19, but also Zika and Ebola. And then I will interview Gregory Makabila and Francis Alumai a bit about their lessons learned. They're both programmers and RIFSAs, and Greg Makabila is the Deputy Chief of Party in Ethiopia at the Ethiopia RIFSA. And Francis Alumai is the SPC advisor, Social and Behavior Change Advisor at Apollo in Uganda, which is the RIFSA in Karamoja. And so with both of them, we'll do a bit of an interview, and then we hope to turn into breakout groups depending on size of our participants, and hear from you also, as to what has worked, what hasn't worked in your experience, and exchange a bit about that, and then end summarizing our experiences and go into next step in plenary. So with that said, I think it's time to hand over to Arianna S. And oh yeah, and what I didn't mention is the interpretation that we have available in French and Spanish. And a bit later, we even have that available for the breakout rooms in both English, French, and Spanish. So please mark up your preferences in the poll as you've done, hopefully already. Anything else to mention about that?
Antje, I'll just mention if people want to turn on the interpretation right now, they should hover over the bottom of their Zoom screen. They'll see a globe that says interpretation, and they should choose their language. Even if you prefer English, please choose the language of your choice. Thank you.
Yes, very good. Thanks very much, Elizabeth. So at the bottom, you'll see a globe, click on it, choose the language of your choice. That will be most, makes it easier for everybody. Great. So thanks and welcome. Please continue to introduce yourself in the chat with your name and title and organization. We have English all the way. Here are the poll results, and we have familiarity, not familiar, some people somewhat familiar and quite familiar. We have a good mix. So fabulous, you're at the right session. So with that said, I'm handing over to Arianna S, and she will let us know a bit more what RCCE, risk communication community engagement, entails and what her experiences have been. Over to you. Take it away, Arianna.
Thank you, Antje. And hi, good morning and good afternoon, good evening to all. So my name is Arianna S, and it's a pleasure to be here. As Antje mentioned, I have worked on several public health emergency responses, specifically on the behavior change efforts. First on the USAID side, including the tail end of Ebola, and then subsequently leading the social and behavior change and community engagement pillar of the Zika response in Latin America. And over the past year or year plus, I've been engaged in COVID risk communication and community engagement. So today I'll be just setting the scene for today's session and talking a little bit about what RCCE is, what we know, and some of the key principles and lessons learned from my experience as well as global experience. So what is RCCE? I think there's a lot of confusion with terminology out there. And quite simply, RCCE is SPC, so social and behavior change efforts in public health emergency settings. And there's a reason why the terminology evolves, which I'll speak about in a minute. The perhaps unique features of RCCE compared to SPC are the accelerated timelines that we work with because of the emergency nature, the extreme importance of national coordination of efforts, the fact that we are working with evolving and rapidly evolving information, as these are usually new emerging infectious diseases, and then really a focus on communities as equal stakeholders in the response, and we'll talk about that as well. And this real emphasis on two-way communication and rumor tracking, which are crucial for the success of any RCCE effort. Stigma is also something that usually comes along with public health emergency, and so we manage that as well with RCCE. But ultimately, in both RCCE and SPC, we are really just addressing the question, what do we need to do for individuals and communities to adopt desired behaviors? So what does RCCE do? In the early days of pandemic and outbreak investigation work, WHO and CDC, who usually led those, used the term risk communication. And it really was very specifically top-down instructions to populations on what to do during an emergency. And this term stuck with frameworks and for pandemic preparedness and response until we realized that it was too top-down. And so then we added the community engagement component and ended up with the RCCE. So the risk communication piece provides timely, relevant, and accurate life-saving and life-enhancing information to communities, which is necessary for people to make informed decisions to protect themselves and their loved ones in the face of a new threat. But the community engagement really puts the communities at the center of planning and implementing these response efforts as equal partners. And we now know that it's extremely crucial for communities to receive information and provide feedback through two-way communication in order to build trust between communities and other stakeholders. And really, whether communities act or not defines ultimately whether a response will succeed. And so we have learned that through difficult lessons in Ebola that if we don't consider communities as key stakeholders that are really active, empowered to take decisions, our mitigation efforts fail. And so really with the community engagement piece, this is a negotiation process in which we need to identify appropriate behaviors based on the local context. And really understand and consider communities' needs and the barriers at local level that affect behavior uptake. So why is RCCE so crucial in a public health emergency? Well, at the onset especially, behaviors really are the only tool we have, and the COVID emergency certainly showed us that, and what we called non-pharmaceutical interventions really, as we can see in the graph here, were for a very long time until we had vaccines responsible for whether we could or not mitigate the spread of COVID. So what do we use RCCE for? As I mentioned, the uptake of prevention behaviors and mitigating the spread, managing rumors and mis and disinformation, which has certainly been a big feature of the COVID pandemic. We use it to address stigma. For the acceptance and uptake of biomedical interventions that mitigate the impact of the disease, such as the vaccine, which is what we're working on now. And then also addressing second order impacts of, an epidemic or pandemic, for example, ensuring that we maintain demand and uptake for other health services, that we are, mitigating gender-based violence and food security and education fallouts resulting from the pandemic. So, from my experience, as well as the global community's experience, throughout these responses, we have certainly learned a lot about what works, what doesn't work, and what we need to do in order to maximize our chances of being successful. And the first element is really coordination. So that's the first principle that we need to apply for effective RCCE. If we don't have strong coordination between partners at national level, especially, although there should be coordination even at global level, we really run the risk of confusing populations through conflicting messaging. So, for example, in the Zika response that I was leading about a year into it, I did a quick review of all the behaviors that were being promoted by our partners, and I came up with over 30. So over 30 prevention behaviors being promoted is not effective and it can potentially backfire. So we really need to, coordinate to harmonize messaging and also to avoid duplication of activities between partners. Second, very important principle, we need to be community-centered, both in capacity building and coming up with solutions. So from our experience, the engagement process really matters almost as much as the actual intervention. And we know there are different learnings about what works in different settings, but ultimately the important part is that local communities need to be partners in the design process for their expertise, their input, their ownership, and their buy-in. So we learned during Ebola that, when the messaging coming from partners, for example, contradicted local burial practices, the prevention efforts really backfired. And so we need to, again, negotiate appropriate behaviors with communities and co-design interventions. We need to be data-driven, so this is around collecting and analyzing information about the communities that we are targeting and really getting to know them. And then an RCCE strategy needs to span across all phases of the response and all sectors of the response. So for example, for COVID, the strategy might start with prevention of the spread of infection through behaviors like mask wearing, et cetera. And then we might move into vaccine acceptance, but then we also include other, mitigation of other impacts like education, food security, et cetera. And finally, just to end it, the key message really is that pandemics start and end with communities. So with that, thank you very much, and back over to Antje.
Thanks very much, Arianna, for this great explanation of what risk communication community engagement is and what your experiences have been. First off, I think I wanted to see if there are any questions for Arianna, and please type them in the chat or ask them straight up, please, so that we have a little bit of time for questions on risk communication, community engagement, and then we'll move over quickly to our interview with our two implementers here, Francis and Greg. So, anyone questions? Risk communication, community engagement? Feel free. We're entre nous, we're among us. I mentioned in the other session that I think we've all been on a steep learning curve. Even people who, like Arianna, have been involved in Ebola and Zika, there have been a lot of new things to learn for us, which is why I think we're holding this session to compare lessons learned and figure out what we can take away for the continued engagement that we're all involved in. So please feel free to ask questions. Anything, anybody? Everybody good? Some familiar faces also for me. Phil, can you discuss different approaches to formative research and social listening as some of the things that have come forward in COVID? Formative research, social listening in emerging infectious diseases. I think, yeah, go right ahead, Arianna.
Approaches to formative research and social listening. So in terms of formative research, we obviously need to use very rapid data collection methodologies. Some of the ones that have been used, actually, even throughout Zika and COVID that are digital have been, for example, UNICEF's U-Report, which allows for some quantitative and some qualitative data to be collected it was initially designed for youth, but then expanded to more of the population. And it's a mobile application through which you can ask questions, do small surveys, as well as poll people, as well as have a little bit more qualitative conversation around what people know, what they don't know, what they're interested in knowing more, what motivates them, etc. We've also done rapid CAP surveys, knowledge, attitudes, and practices surveys using mobile phones. Those have, some technical constraints that sometimes affect the data. And, essentially you can use any methodology that is rapid. So, adapting what we normally do for the emergency context. Social listening, actually, I think Antje probably has some great examples also of this from COVID. Antje, do you want to take that one?
Yeah, sure. And I think, to move things along, I think we'll hear some of that also from Francis and Greg when I ask them in a minute. Social listening, I think what's important is to have a feedback loop. So social listening is a very broad term at the moment that covers, normal feedback loops through hotlines, through WhatsApp groups, and all kinds of other methodologies. What is important, I think, is to have a consistent feedback loop to understand what misconceptions are still out there, what community solutions are out there potentially that we haven't seen, and to stay in dialogue, not to, as Arianna showed in her last graphic, not to spout messages and be, and have your ears closed, but, be able to listen to what's coming back. One more question before we jump over is, there is a risk in having too many different messages, and having a non-manageable size of actions, behaviors in the pandemic. So Arianna, if you can very quickly talk about what you've done in Zika to address that, and then we can move on with Greg and.
Sure. So as I mentioned during the Zika response, we found over 30 behaviors being promoted, which in some cases within the same country and context. And so we address this by going through a prioritization of behaviors process or exercise, where we developed criteria for effectiveness of each behavior in preventing transmission of Zika, and layered those, that criteria onto others, such as feasibility of the behavior in the context, and expense of the behavior, etc. And through group consultations with partners over a period of time, we've managed to narrow down the behaviors from 30 to 7. So, and mainly agree on what the priority behavior should be, and then all partners were promoting the same set of behaviors.
And we can talk more about that later on if that's an interesting question for you. I know it's for all the RIFSAs, and you know, in our ideal SBC tab, we've been talking about prioritization and how that's done. So happy to answer that. But I wanted to get over to Francis Alumai and Greg Makabila, because both of them work in quite difficult areas. You know, Francis is right now in Karamoja, Uganda, where the pandemic is actually quite strong at the moment, and vaccinations are fairly low, and access to vaccines are also low. And Greg, you are in Ethiopia, and you also had to deal with a lot of rural, hard to reach populations. There are literacy issues, there are local language issues, there are issues with access for women, for example, to radio and mobile phones. So both of you worked in basically this area where, you know, there are a lot of lessons learned. So I wanted to start off maybe with Francis, who is the SBC advisor in Uganda for the Apollo RIFSA. You know, what approaches have you been using when you started integrating COVID-19 risk communication and community engagement approaches into your ongoing SBC activities? So my first question, what approaches, and then we'll go to the next one later on, what have we learned?
Okay, thank you, Antje, and all who are on the call. As you can see, I'm on a mask, and I'm talking from our office in Karamoja. I will be adjusting my mask a little bit so that I can be able to talk well, since I'm a little bit of a distance from my colleagues. So, like Andy has mentioned, my name is Francis Alumai, and I'm the SBC advisor for Apollo activity. Apollo activity aims to improve food and nutrition security for vulnerable agro-pastoral communities in rural Uganda, specifically in Karamoja, the northeastern part of the country. And it has a very heavy SBC component that Save the Children is leading among the other partners. So given the onset of the COVID-19 pandemic, we quickly made a turnaround and adaptations to our activities. And the one thing that we did to integrate RCC was to embark on road drives through the rural communities. These road drives had the megaphones where key messages on the pandemic were being disseminated, but also a focus on the key priority sectoral behaviors were also integrated into the road drives. These road drives were a non-stop because we know that once they stop, then they will attract a crowd. So they'll move at a moderate, slower pace while disseminating key messages. As the road drives take place, you'll find communities in the neighborhood get alert wherever they are in their homes, and then they tune to what is going on through the road drive. And it really got the attention of the communities. In addition to that, we also had a radio programming where we coordinated with the Ministry of Health and got the approved key messages on COVID-19, and these were being played on our radios. And then we also had the interactive radio talk shows where we had the key technical people from the health department of the districts coming to talk to the population. And then also some elders, the cultural leaders coming to the radio, basically for myth busting, because a pandemic like this that has not been there in the history gives a lot of mixed reaction in the population. So when a local population listens to their own leaders, they take the messages seriously. So the radio programming was not limited by any of the restrictions. it allowed for this, the social distancing opportunity for people. And given the fact that there was total lockdown, people were staying home. So families were attending to radios, and so they had all the time to listen to these messages. The other thing we did was, instead of mass community engagement, we adopted a localized and targeted behavior demonstrations at the household level. So we would go to a household and then engage the household members, who would be from 7 to 10 in number. And this made social distancing easier. And then also during these behavior demonstrations, like in hand washing and then other behaviors, we were also able to keep distance away from each other. And so this helped the project teams to be able to comply with the restrictions. Relatedly, we also adopted mobile phones for remote extension support services with the farmer groups, livestock groups, where we got in touch with them through mobile phones. And as we guided them on agronomy, on the livestock management, we were also emphasizing on how they could keep safe. So while the project teams were locked down at their homes, they were able to make a follow-up through this kind of arrangement. So this demonstrates how Apollo integrated RCC into program adaptations during the wake of the COVID-19 pandemic. I will stop there. Over to you, Antje.
Thank you very much. That was very interesting and good to hear, how you already adjusted basically the ongoing vehicles and channels to integrate COVID-19 information and feedback. Greg, do you want to talk about what you did in Ethiopia? What approaches did you use to integrate COVID-19?
Yes, thank you. The problem we were solving about our clients was misinformation and lack of information on COVID. Because when COVID-19 hit in March 2020, the messaging was mainly focused in the area around Addis, because most of the cases were within Addis. And the channels being used was mainly radio and social media. And our clients who live in the remote areas of Ethiopia, where we work in the 9 waredas or districts, do not have access to internet. The literacy levels are very low in some of the areas, and movement and communication in the area is generally a problem. But the good thing is that they have consistent access to telephone calls, so they can receive messages, they can make phone calls, etc. So using this as the background, we decided to reflect internally and agreed that one of the most effective ways to do this was to reach them through a technology called interactive voice response. For most of you who are called a mobile company or the help desk, you get things like to English, press 1, for Kiswahili or another, press 2. That's basically interactive voice response, whereby you call, you pick a message that you want to listen to, etc. So we set up this tool with a partner called Veamo, because we had an existing relationship, which brings in the speed at which we managed it. It happened within 5 days. By 5 days, the thing was already rolled out and moving. We had pre-existing messages because there was a good coordination mechanism at overall stakeholder level, where the government, USAID, and other actors had messages in Afan Oromo, Somali, and Amharic. And good enough, those are the same languages that we are using in our area of implementation. So we pulled out this technology together. We implemented in our implementation areas, and we show some reasonable amount of success. Our staff in the community trained the participants on how to use this technology during community distribution sessions. They demonstrated it there. The people tried it, and it worked very well. On average, up to now, on a monthly basis, we get around 1,000 callers and beyond. Our target initially was to get 1,000 to 3,000 callers, and we superseded that those numbers by the way the meeting goes. The last point I'd like to mention is that through IVR, a person is able to repeat the message. So what we noticed is that even though we had on the first month around 1,200 callers who are unique callers, we saw duplication within the system whereby they were calling 3 or 4 times. So we had like 5,000 or more calls being made, even though there are only 1,200 unique callers. So when we did our annual survey later on, we had hit 3,000 plus callers, but when we asked clients, from our data, we noticed it had hit more than 20,000 clients just through the repeated messages at home. When we asked why, the people who got the number, they receive the message, then they go and sit down as a family and they listen to the messaging, which helped them because not everybody in the households have access to phones. Thank you.
No, that's already a great lesson learned, you know, and how the importance of data also around these interventions. Greg, I'm going to just continue with you to ask you, you know, what didn't go right? Because this is the session about the things that we can learn faster because they didn't go right, and how did you adjust?
Thank you. One of the things we learned is that learning and being proud of your mistakes helps you to learn faster. One of the things that didn't go right, IVR was not new to us. We had failed again and again, and this was the 4th year of implementing. One of the things that had failed is that when we set up our initial IVR, what I can call the primitive IVR, we had the script structured in a way that because of our M&D lens, we wanted to know what is the name of the participant, where do they come from, where are they calling from, all those demographic information. And then the last message was, what do you want to complain about? What feedback do you want to give us? So that alone, from our data, we had 250 attempts to call, but only 30 of them had gone through. So when we went and asked the client, they told us, just let us go straight to the point. Don't go too much with those demographics. So when we flipped this around, we had almost 80% completion of the calls, which was not the case. And when we brought this same lesson to the COVID-19 messaging, we had the same rate, over 80% completion of the messages, because you know there were 6 messages. So if they drop out at the first message partially, it means they miss all the 6 messages. And that is one of the biggest lessons we learned, structuring the call and taking the key message as a priority rather than doing about the demographics. So all our IVR scripts now, they're structured, starting with the key message and then ending with the demographics. And we are still getting to know who called, what sex they were, and where they're coming from. That's one of the lessons I would like to share. If you know the others, thank you.
Thank you for that. So clearly staying in touch with your audience and figuring out when things don't work well, ask them why they don't work well, and then adjust. Very good. Francis, what didn't go well with Apollo? Where did you have to adjust?
Okay, thank you. Like I mentioned, the radio programming was the ideal channel of community engagement by that time. And it enabled the program team really to get in touch with the communities. But we learned that messaging without close interaction with the communities was not enough for behavior adoption and maintenance. So while a lot of messaging was done, the fact that we were not able to maintain touch with the communities, you know, was not enough. And so what we did was, when the lockdown began to be relaxed, then we embarked on a follow-up visits, especially with households where the program teams had a behavior demonstrations to find out how far they went, what hurdles they had in adopting the behaviors, and then they picked up from there in terms of mentorship coaching on these behaviors that were demonstrated. So this clearly indicates that information in itself is necessary for behavior change, but it is not enough, you know, to drive skills to practice level. So that was the key learning from Apollo, in addition to the others, which we can discuss later on. Thank you, and over.
Yeah, thank you very much. No, very important lesson learned. So I think this goes back to what Arianna said. We have risk communication, and then we have community engagement, and those two are twins and connected at the hip, both need to be used. So we have a little bit of time, so I would like to open it up. Any questions for Francis and Greg from the plenary? Please type them in or just ask them straight up. Now's your chance before we go into small groups. Anything else about lessons learned, mistakes made, or just about the 2 interventions that were described? Don't be shy. Oh, here we have from Jose, Greg Francis, did you compare the change in targeted behaviors and their respective barriers determinants with new approaches compared to that prior to the pandemic? Did you compare the change in targeted behaviors?
So I'll actually talk about a potential negative change, not positive, because we monitor both changes. During our annual survey data of 2020, we noticed that then their messaging on what wash, they're like, what are the hand washing moments, the critical hand washing moments? That number reduced from the previous year by around 5%, which normally is not the case because that's one of the easiest behaviors. And then when we went down to find out why exactly this is the case, we noticed that people focused more on the how to wash hands as they were being taught in the COVID-19 situation. So all the messaging from us, from other actors, were focusing on how to wash hands in the context of COVID-19, to the extent that anytime we talked about hand washing, what was being remembered at that point in time was COVID-19 and not the behaviors we had been promoting the previous years. So that was not really bad completely, because at the end of the day, they were washing hands using the critical moments, but the knowledge on that had, I don't know if it had gone low, but they prioritized the messaging because there was more repetition on the COVID messaging. That's what we got to understand from them. But we noticed in other aspects, like for example, the hand washing stations grew up because stakeholders gave more donation of hand washing stations, and people took it more seriously through our approaches, including the community-led total sanitation. And then we also noticed like more frequency of hand washing among the clients. So those ones are compared to our previous year's data, without not necessarily taking COVID-19 as the baseline, but that's the change we noted, and in our deviation, we use that as an explanation. Thank you.
Yeah, and there may have been a tipping point reached with hand washing. People knew before, so that was kind of maybe an easier change to make, or finally a change that they made, because there was more urgency based on all the previous. So Francis, anything to add? You know, have the new approaches you used basically, have they shown results that older approaches haven't? And that's basically a question, will we use them further on for, you know, for the other behaviors?
Yeah, I'm just going to cite an example in the wash sector. I'm looking at RCC strategies and the enforcement. During the pandemic, there were key guidelines and standard operating procedures that were in place, and these were being enforced at different levels, while community volunteers and structures talk to people. They use the cognitive approach to convince people, you know, uptake hand washing behaviors. You'll find the local leaders, like on the government side, the local councils use a kind of the government way of enforcement. And so these two approaches led to households putting in place hand washing stations, you know, for the sake of, you know, pleasing whoever is enforcing it. But in terms of usage and the practice, it was low. Mm-hmm. So people went into a massive establishment of those hand washing points, but then the hand washing itself was really minimum. The thinking was that with the onset of COVID-19, wash practices were actually going to scale up, which was not the case with the hand washing. So when you go to communities, you'll find hand washing facilities that are not being, you know, regularly used. So basically, it pointed to an issue of attitude, an issue of belief, you know, as factors that will promote hand washing. So they were simply set up to please those who were enforcing it. So in RCC, I think it was an issue for us to think about. RCC and community engagement through enforcement.
Yeah. And another example of if you build it, they don't come by themselves. There needs to be more SPC support for that. Good question. Any more questions, for Francis and Greg? And good points made just now. Good lessons learned. Even if there's more enforcement, which we often wish there would be, it doesn't mean that the behavior changes. Anyone else? More questions for the two before we go into small groups? Not really. Good, then Maya, if you can put us into two groups. So what would follow now is we would like to hear from you actually, on your lessons learned. We wanted this session to be an exchange and, to provide a safe space actually, for us to say, hey, what didn't work well and how did we adjust? Because we're all on a big learning curve with COVID-19, especially if we have to integrate it into ongoing programs. That has not been easy, is not easy currently, and will probably also continue. So I hope you can use this opportunity in the small groups to exchange, and then we'll come back to plenary and maybe pick up some key points.